We are live.
Good evening and warm welcome to all joined in today. Welcome to Gyan Pravah Podcast Series number 127. This is a wonderful and insightful initiative of our dear FOGSI President this year, Dr. Sunita Tandulwadkar. And it goes this way. ज्ञान का बहता एक नया रंग हर रोज रात 8 बजे जुड़िए सब मिलकर फॉक्सी के संग. I, Dr. Sita Ramamurthy Pal, Chairperson of the Genetics and Fetal Medicine Committee, FOGSI, is your host for tonight. And on the 4th of every month at 8 p.m., I bring you legends and experts in the field of fetal medicine, where we explore the science, the narratives, and the changing paradigms that happen in the field of fetal medicine and genetics. And today, our guest speaker is none other than our own esteemed Foxian, renowned fetal medicine specialist, Dr. Prashant Acharya. And the topic tonight is exploring latest technologies and their impact in the diagnosis of fetal conditions. And Dr. Acharya is at the forefront of this transformation. Thank you, sir, for accepting our invite and being part of our podcast series.
Thank you. Thank you very much, Sita. And thank you, Sunita, for inviting me here.
Thank you. So before I introduce Dr. Prashant Acharya, it is my privilege and honor to welcome and invite Dr. Parani Appan, who's the current Vice President FOGSI. He is the chairperson and, sorry. He's the professor and unit head department of OBGYN, Sir Ramchandra Medical College, Chennai, and he has won several awards and he has been at the forefront of obs-gynae in our field. Thank you, Parani. And with all the multitude of projects Dr. Sunita Tandulwadkar has done this year, all our vice presidents and chairpersons are very, very busy keeping, doing it. And thank you once again for joining us this evening. Thank you. Few words from you before we start the podcast.
Thank you, Dr. Sita and Dr. Prashant. I give a very warm welcome to all the Foxians and the non-Foxians who have logged into this wonderful program of Gyan Pravah Podcast of Dr. Sunita, an absolutely wonderful initiative which is started. So all the days, 8 o'clock, whatever you're doing at home, whether you're in the clinic, whether you're in the kitchen, or whether you're in the bedroom, you could switch on your podcast, hear to it, and then get enlightened by these speakers. The speakers and the specialists may be from the field of obstetrics, may not be from the field of obstetrics. It could be a politician, it could be a sportsman, it could be an entrepreneur, it could be anybody, and we would get lots of words of wisdom from each one of them. And so this is an absolutely different initiative of Dr. Sunita this year, and the chairpersons are given specific dates on a different month. And as Dr. Sita said, this is the 127th podcast we're going on. Absolutely brilliant and very successful. And all of them are recorded so that if you want to go back and listen to on a later date, you could still do so. And Dr. Sita, as we all know, has been working on several projects, and she has taken this podcast very seriously. But I'm sure it's going to be very light because we're having Dr. Prashant Acharya on the other side. And so the interaction between both of them is going to be absolutely stunning. And I'm looking forward to see what both of you are going to talk. And so with that, I welcome Dr. Prashant and, of course, congratulate Dr. Sita on such a wonderful podcast. And over to you, Sita. Thank you very much for involving me.
Thank you. Thank you, Dr. Parniappan, for joining us and giving us your words of wisdom. It is true, actually, that with this podcast, we ourselves are evolving and we're getting to know ourselves as how to, how we're going about this. And Dr. Sunita Tandulwadkar has given this bright opportunity for all of us to, evolve as leaders. So thank you to her for this initiative, and thank you, Dr. Parniappan. So as it goes, after this, Dr. Parniappan will log out and we will continue our podcast with you, sir.
Thank you.
So, right. So it gives me immense pride and pleasure to introduce one of the pioneering and globally recognized experts in the field of fetal medicine, Dr. Prashant Acharya. Dr. Prashant Acharya is the medical director and chief consultant at the Paras Advanced Center of Fetal Medicine. He is the founder secretary of the Fetal Brain Society, the first of its kind in India. He's also the co-founder of www.scan.academy, where we have learned multitudes of lessons from experts all across the world. He's the INSWOG Fellow 2019, the first Indian to be honored with this title. He's been the ISWOG board member and trustee from 2015 to 2019. Also has been the ambassador of ISWOG to Asia and Pacific regions from 2014 to 2020. He has been in the list of international faculty of speakers for ISWOG. He's the founder, trustee of the Indian Society of Ultrasound and Obstetrics and Gynecology, which is INSWOG. And he's been our own FOGSI vice president in the year 2012. And proud to say that he's been the committee chair of this own Genetics and Fetal Medicine Committee, where he's been an immense guide and advisor for all of us and me too. So thank you, sir, 2010 to 2013. Has been the council member of our ICOG from 2012 to 2016. He has been involved in teaching and training ultrasound and fetal medicine since more than 2 decades, and he continues to do so with the same dedication and passion. And thank you, sir, for that. We all enjoy your lectures and look forward to your talks always. He has given over 600 guest lectures across 22 countries. He has numerous publications, 1 textbook, 3 books, and more than 24 chapters related to obstetric ultrasound. He's specifically interested in all, I think he's an expert in everything, but the most interest bit is 3D, 4D ultrasound and his pioneering work in knowledge in fetal autopsy and fetal interventions. Sir has authored the very great book, The Ready Reckoner for all of us, 100 Thumb Rules in Obstetric Ultrasound. So thank you once again, sir, for joining us, and we'll start our podcast. Thank you. So today we are going to discuss about the latest technologies that fetal medicine has gone through over the years, sir. And I think, you are the best example of how it has been through. You have seen it all. So if we start with imaging, we have seen 3D, 4D, and now, though MRI has its place in general radiology, in fetal medicine, it is sort of evolving technology even now. So how do you see yourself, sir, that these tools have changed your practice in these years? Your experience and what, sir?
First and foremost thing is now obstetric practice without ultrasound is not possible. Previously, it used to be a stethoscope and only 2 digits. We feel that obstetric is being done if I got a good to feeling and I could hear any variation in the heart rate by the stethoscope. It has completely changed since last, I think, 2 decades. 2D ultrasound or a grayscale ultrasound is very vital, very important. But addition of 3D and 4D has given much detailed information about the fetus, much detailed diagnosis. It's not only about the diagnosis. The moment we are there at a diagnosis, then we kindly, we try to follow what kind of treatment, what kind of management. Will she need in utero management? Will she need a tertiary care center? Or she can be delivered at any of the hospitals? So that will be also decided by advancement for the diagnosis to the fetus. One important point this 3D, 4D gives you, that if you take a 2D sweep, if you store it, it is the same section you will be able to see even after maybe any time when you want to see the patient. But volume 3D is giving you the volume. It gives you the whole data of the entire fetal structure. So it can additionally give you a lot of information. And one important clue is if you said that a fetus was normal when I scanned it and baby turned out to be having some malformation, a 2D clip will not show you anything extra. But 3D you can manipulate, you can audit yourself and try to find out why I missed something or what was lacking there. So that's what enhanced visualization and diagnosis is the key for 3D and 4D the diagnosis. It will also improve the prenatal counseling. Also, it will help in decision making, where, when, and how to deliver. One more important point is this about 3D, 4D is it's not replacing your 2D evaluation, but it adds on lot of value to your diagnosis and your evaluation of the fetus. So 3D definitely has advantage over 2D, but 2D knowledge is must. If you do
This
not know how to perform your 2D examination, you will not be able to do your 3D, 4D evaluation.
True. So what about fetal MRI? How do you see that has improved your understanding? Do you think it still is especially in our country, do you think it is still a niche area? Or, when we talk about, when the West, when we go for conferences, they are talking about as a mandatory, or, it's more easily available also, which is also a question. So how has it changed in your practice? I'm sure you're using it. Um,
Yes, MRI is one of the important tool, especially when there are few indications, specific indication when you should utilize MRI in low resource setting. See, you have got all the resources available, patient is affording, they want everything additional diagnostic method. You can add MRI as an investigation part, even it at 22, 24 week, if you have slightest doubt. But the moment you have got a resource settings which are low, or you are in a private practice where patient is not that much affording,
hmm,
or in a government setup where you have got, you can't write prescribe MRI, okay, you get it done MRI this and that, and availability is also a question. There are a few specific indication when you should do MRI. First, whenever you have got any CNS malformation after 24 week of the gestation, especially when the fetus is in breech position,
yeah.
because the access to the fetal brain, which is limited because of the skull bone ossification, and second, because it's a breech, you can't have a transvaginal neurosonogram done. These are the two things, these are the two reasons why I will always advocate any CNS defect after 24 week or 26 week of a gestation, because it adds a lot of value. The moment ultrasound has got its own advantages, but MRI will add a lot of value to your CNS evaluation. So that is one point. Second, if somebody wants to confirm that, no, I want another modality, if you have got a ventriculomegaly, now couple says, no, I want to diagnose. So I would advocate, rather than a second ultrasound examination or a second opinion on ultrasound, I would advocate MRI. So that will change the modality. It may add on information. Second point, when you have got a complex anomaly, brain, heart, skeleton, spine, many things are involved at a go, then you will have, MRI will have definite advantage. One most important point is MRI, as far as, because we all are obstetrician, I would always advocate MRI whenever you have got a previous uterine surgery with a possibility of adherent placenta. We do not want to end up in any scenario where you have suddenly you open the abdomen while with a previous cesarean section or a previous hysteroscopy or some kind of fibroid myomectomy or something, and you find a placenta is adherent, you are not prepared for it, blood is not readily available, and suddenly you are in a problematic situation. So we do not want to end up in that scenario. So that whenever you find that there is slightest bit of possibility of placenta being adherent in case of the previous cesarean section with an anterior placenta, or a placenta adherent at a site of a myomectomy, or that kind of scenario, make sure that you have done fetal MRI, so that you can save yourself, you can save the patient's life, and you can also add on a lot of value to the fetal diagnosis. Of course, you need to have the support in the government hospitals. You
I
need
was
to
just
have
coming to that.
expertise. You need to
Yeah.
have the expertise, and that's out. But there is definite role
So,
of these
because
elements.
as you said, the fetal MRI in terms of complex CNS anomalies and placenta, the other important thing, isn't it, sir, that to interpret these reports. A lot of them, even in our center, we had to really push for a corpus callosum agenesis that please do the MRI, and and then they sort of started doing, and a lot of times they depend on the ultrasound report, sorry to say, and then they say, okay, so that is also a fallacy where we get stuck, we're looking for more information. And as you said rightly, in the government sectors where these patients come unprecedented, we don't know. So how are we going to equate in these urban and rural centers these evolving technologies, sir? What is your thought process
I,
on
I, I tell you, first and foremost, in India, yet even today, fetal MRI, if you ask me really honestly, there may be 10 to 15 centers who are genuinely performing the fetal MRI and correct reporting.
Supporting, yes.
They all are in their infancy, or I would say intrauterine life for their fetal MRI reading. So
Right.
they need to update themselves. Not only that, it's all about high resolution. And then there are, if you go really international fetal, if you really look at international scenario, people have started doing tetrography and try to predict. Say, for example, you have got a ventriculomegaly, and in ventriculomegaly, if all spinothalamic tracts are normal, then you expect a good outcome. If in case of ventriculomegaly, those spinothalamic tracts or the cerebral cortex or those white matter tracts, they are inappropriate, there you expect it's not going to be that great
Outcomes.
outcome. So
Yeah.
it tells you about how the development in the brain which is happening. But right now we are lacking that spectrography. Very few centers, you can't even like there are
Sound
only
point.
centers across India who are performing spectrography with the precision. It's not about getting a tract is easy. Just you press your mouse, tuck 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 tuck, it will create a tract. But to correct tract and interpretation of the tract is really vital, and we need it. Second point, there is that we should have a little more awareness about, not only to the public, but it is OBGYN and radiologist all should have a real good knowledge when to ask
Ask for
these
this.
MRI investigations. Of course, the very limited resources from the government. You can't have, you don't have that support. You don't have 3 Tesla MRI everywhere. You have 1.5 Tesla with the low end, where it is always going to be difficult as because of the fetal movement, the capture. It may take longer time than the usual other MRI. Adult MRI brain, adult MRI abdomen will take hardly 20 minutes. Here you may have to wait for 2-3 hours. In a
Yes.
government setup, you don't have that time. So you end up in okay, nahi ho raha hai.
Yeah, I get it.
Let us move to the next patient. So that happens. A training, expertise, and a dedication from a team. Okay, I want to do fetal MR. If you have it, then you can have it.
Yes, sir. So that's very important. I think the awareness bit, especially amongst our own colleagues and the other specialities, that we can do this and we need to develop it better to counsel the patients better, isn't it? We are in a better
Yes,
position to tell them how to go about this pregnancy
yes,
rather
yes,
than,
yes, yes.
especially in neurological, I mean, brain abnormalities. It's very, very difficult counseling. I know, we know
Yes.
that. But sir, how do you think the government and the private hospitals play their role in in making these technologies available or equal access to all these? How do you think it can get better? Your any thoughts on this, or your opinion on this rather?
Yeah, I tell you one thing, that when you want to make these investigation available to every human being or every pregnant lady, all sector of the healthcare should come together and have that zeal. First and foremost, in India, government sector, where you have more than 60% of the patients which they are flowing there. Second is a private sector, and third is a trust, or some kind of those hospitals, bigger hospitals, but in a private sector, or bigger hospital in a trust or a low resource setting sector they are working. Now those who are in a private setup, they have to either reduce the price, or government sector has to make it available,
Level.
or third thing is all these trust hospitals and a private sector setups, they should give an access by the way of public private partnership, or maybe there are many modes and modality. Eventually that cost has to be reduced. Okay, the cost can be reduced by many ways. Say, for example, I will give you simple access about the MRI. Previously, the MRI used to cost almost around 15-17,000 before I'm talking about 2-3 decades. Okay, when MRI was not available readily for even for the adult brain. At that time, charges were high because the expertise was not there. The charges of the machine installation was very high. So the cost was very high. Now, simple MRI brain, you can get it done in, say, maybe 1,200 rupees or 1,500 rupees, because there is vast availability of the instrument mechanism and more competition which is created. more competition which is created, that is indirectly increase the accessibility. The moment you increase the accessibility, the cost will come down immediately. You can also think about subsidizing testing, which subsidizing testing can be provided by either by the government setup or even by a private setup. Occasionally we also subsidize the patient. Okay, whatever I'm charging, the patient needs something. If somebody
Needy
sent
patient.
patient, okay, please take lesser charge. We never said no, 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 I will charge this much only if you want to send it across. So
True.
we all, after all, we are doctors,
Yeah,
human, better
exactly.
human beings, and we consider always there may be exceptions in 1 or 2%, but 98, 99% we are really good. I tell you, I can promise that part. So we are really good at understanding the need of the patient, and we will always put it across like that. The moment you improve your PHC care, but you know that how is the PHC care or primary health centers, they are really lacking services in lot many aspects. We need to improve our primary care, or even CHCs, that is a community healthcare centers, or even to a government setups or hospitals. I tell you, very few government setup has got genetic testing laboratory even today.
True. Yes, yes,
Right. So if that is not there, what these patients are going to do?
absolutely.
They are the costliest tests available.
Mm.
So there are things which needs little much more assessment and implementation of the care. And of course, a public private partnership can help to implement these costly diagnostic tests, or else government can have a collaboration with the private centers, that okay, if at all government patient comes to your clinic, please make sure, or a referred from a government setup, please make it. That's what we do it in our private practice also. A patient comes from a government setup, we give us a quite subsidized charge. If at all, if moving further with the latest technology of telemedicine,
Yes,
you can always take help of these telemedicine. See, ultrasound we do very regularly. If you are a user of a G machine, I ask them to send me across .4 dB file. They send me the file, I open in my machine, and I look at the patient as if I'm examining the patient. Those data I can reassess and give the help from a distance. I can help them. This
absolutely.
we are offering for all international patients. We get the data, we analyze, and we try and put it across like this.
Yes, sir. I think telemedicine has come a long way, even for general consultation. The government hospitals are using it for, outreach patients or in the way. So I think this can, when we have said that ultrasound has replaced our stethoscope, so I think this should
Yes.
immediately go in as our place. But, I think when people say, when we talk to our government, partners or colleagues, they'll say a lot of the patients don't even get a basic ultrasound done. To ye kahan se hoga? But I think that it's the mindset, isn't it? I mean, we have to move forward and tell them that, no, I mean, this is something that we can be done and we should aim for it, because we have the expertise, and it is just, if we aim, if we train ourselves, thinking and training ourselves will be good. What do you say?
I'm also attached to one of the government medical college. Just retired from that. Now I've joined one more medical college, that is Narendra Modi Medical College. We know what is the scenario. You have load of the patient, but the moment you have appropriate scanning at appropriate timing, you can cope up with that load. You can always offer them the best possible evaluation, so that you can help and you can diagnose. So there is nothing impossible. You
Exactly.
learn how to make it possible.
True, sir. So moving on to our next, expanding technology, which is AI, which is coming up is there already. And I think, some of the colleagues, if I speak to, not colleagues, experts in computer science, they say that it's going to take your job off, take your profession away. But what do you think the real world users for AI in fetal diagnosis is at this point and, way forward?
See, the yes, AI is going to help you, but it's all how you deal with it. Okay. Now I'll compare it with like mobile technology. The mobile phone, which we had a very simple phone.
Just
You
to call
you
and
were
say,
you were, I mean, you were making call and receiving the call.
Yeah.
Now it has gone to email, and like a small little computer you have on your hand, and you can do everything.
Everything.
Right. Now, the moment you know that if you become slave of your mobile, you have got problems. If you make your mobile your slave to help you in your day-to-day work, it's really helpful. The same way is for artificial intelligence. Make sure that the AI technology you utilize to make sure that you make AI your slave. Don't be a slave of AI. The moment, so a simple example I'll give you. Today, many of us never think of writing an email by ourselves. They put it to the Google. Okay, write down one email to Dr. Sita Ramamurthy to thank her that okay, you have done a good podcast. So chat GPT will write down, and you copy it and post it. You have no clue what is going on, and your mind never works after that. So this is exactly what I do not want you to do it. You take help. The moment AI will it's being trained. It's a computer. It is trained for identifying malformations. Yes, it has. You have fed 100,000 images of abnormal corpus callosum, and the moment you have got next abnormal corpus callosum, it will tell you that okay, it is matching to this image, and it might be absent corpus callosum. That is making your life easy, but you need to confirm. Okay, yes, it is really absent corpus callosum.
Fair not,
And
yeah.
then what? So these are the things where you have to have this, but make sure that AI being utilized for a better image quality. It should assist you in evaluation of the patient, rather than it is going to diagnose your malformation and tell you that okay, do that, and you start doing working that. So no, 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 it's not going to replace you, but make sure that it doesn't replace you. It's
Yes, that is
your
it.
hand.
Yeah.
That you should do it that way. So it is as such, AI is really very vital in probably analyzing a very complicated data. Make sure that you have a complicated scenario, you give everything to AI, and it might give you a few of the suggestions. Then choose, is it what is correct and what is not correct, and you should utilize that AI for that reason rather than anything else.
Absolutely, sir. Very, very beautifully put. I think I somehow feel good in this part, but being medical professionals, I feel our things cannot be replaced because we still have our clinical acumen somewhere. Because the engineers and the other professionals might be at fear of getting replaced by AI. I don't know. I cannot talk for them, but for us, at least we have our clinical acumen, and we say, and as you said, to put into perspective the patient's condition and what you see, and
Yes.
then I can help you. So, sir, as you said that, technology is very powerful and we are using a lot of these technologies. So how does this help you in counseling patients? You've told about a bit, but it is also complicated when you're trying to do more, especially in terms of genomic testing and everything. You do one, you're looking for one, you find something else. So, do you think more technology is more confusing the patients? Are we, has it worsened your counseling or bettered your counseling in terms, not
It
worse, I won't say worsened, but, complex the counseling bit so as the patients get more worried and scared and confused.
See, I tell you again, I tell you one thing. The moment you have any scenario in the life is always has got something plus and something minus. Okay, so something advantage, some disadvantages. If you want to have advantages, you should know what are the disadvantages and how to tackle with them. It's like it's like doing a cesarean section. If you know only what are the good things, then you can't deal with it. You have to have the precise idea what are the possible complications and how to deal with those complications. The same things are applied in all these genomic testings or any. I will give you a typical example of us. VUS is it is they said that is variation of unknown significance. Okay, so that means something is away from normal, but right now I do not know whether that is normal or abnormal.
Absolutely.
That they are all known as VUS.
Yeah,
Okay. One thing is very sure that this is not a normal system.
true.
Okay. Now today that system or that VUS may be no a VUS, but tomorrow this
Might be
VUS,
pattern.
it can be a pathogenic.
True.
A VUS today, which has got VUS, which is homozygous, and the couple, they are heterozygous carrying the same mutations and the syndromes or whatever phenotype, they are exactly matching what these VUS can cause, then you should consider it as a pathogenic rather than considering it VUS. So it's
Yeah.
all about how you are taking that system and how you interpret. It's not, don't always try to translate this English into your local language. The moment you do it, you are gone. Okay. So it's always never ever think translate this exact English into your local language. So I if I put convert into your Hindi, मुझे पता नहीं इसका significance क्या हो गया. Am I right? This VUS
Yes.
means that.
Exactly. Literal translation is
I'm just literally translating. So लेबोरेटरी ने आपको बता दिया इसका मतलब नहीं है, मुझे पता नहीं है आपको इसका क्या होगा, सही होगा गलत होगा वो आप जानो. If at all you are in doubt, you can counsel exactly like this, that today this is the information. I do not know what this VUS can cause and it may be pathogenic. If you want to take risk, then continue the pregnancy. If couple says, I do not want to take risk, even on VUS, what can you tell them? Probably you can't count. You have no right to say no, you have to continue.
it is their
Say, I
choice.
don't want to take risk. Am I right? So it's all depends upon what is the risk appetite of that particular couple in that particular scenario. I'll give you one classic example. One patient came before 6 weeks to us, referred with a report of NIPT. They suggested mosaic trisomy 7. NIPT suggests mosaic trisomy 7. Okay. So we said, okay, we need further evaluation by doing amniocentesis, and then you have to counsel. Then we will discuss how the things are. Amniocentesis was performed, and in amniocentesis also they said there are 20% cell which are shown as a trisomy 7, 80% shows normal karyotype. Okay, now the question comes, from where this amniotic fluid gets the cell. If there is a placental mosaicism, still it is going to secrete into the amniotic fluid. Part of the fetal body, if it has got a trisomy 7, it can also exfoliate. So next is what? You have to do photosynthesis and then decide. So it's all really making the life little complicated from trisomy, mosaic trisomy 7 in NIPT, amniocentesis confirming. Now nobody is going to take risk. You have to, next step is you need to confirm from the blood. Is it anything? It is there. If it is there in the blood, then it is confirmed that the fetal body has got some part which has got a trisomy 7, and there are high chances that that part of wherever it is, it may not function appropriately and can cause a problem. So you have to explain the same thing. You have to explain the VUS to the couple. You also need to discuss what are the limitations of any technology which is being used. Make them educated to understand what this VUS means. And today it is VUS, tomorrow it can be pathogenic. Right now it is classified VUS, tomorrow it can be classified in pathogenic. So eventually the data, more and more data being utilized, same phenotype on ultrasound, this is genotype finding, and eventually this is being added into the database which they are querying. So it adds on the things. Of course, in this scenario, you should counsel a geneticist. If at all it is in your team, they can help you and try and access these conditions.
Thank you, sir. Thank you for that. That was very interesting. So ultimately, what did the patient do, sir, for that? For the trisomy 7?
So I ultimately we did photosynthesis, and that photosynthesis confirmed mosaic trisomy 7, and they did not continue the pregnancy.
Okay, okay. So in terms of, when, as you're saying, we're diagnosing more conditions, do you think as a country, our country, India, is it more ready now to handle the, ethical implications of diagnosing all these conditions, possibly earlier, especially when you do such brilliant ultrasounds and you're able to diagnose them in the first trimester? how are the patients able to handle this, in terms?
India,
Because a
India,
lot of our conditions are being diagnosed in the first
yes.
trimester.
Now, India has got very typical system than the Western world. Never ever compare the Western data. Never ever always apply to Indian system or Indian scenario. Counseling is never applied because there are a lot of differences between India and the Western world. First is lack of education.
Mm.
The in general, the public education is really very low. Second thing is, when you explain this complex situation to the couple, hardly they understand. And whatever they understand, next question, sir abhi aap batao humko kya karna hai.
True.
Right, so they will ask you to make decision. Normally we usually always blow a trumpet that it has to be an unbiased counseling, blah blah blah. See, it doesn't work always in India. Ideally, I agree, it has to be unbiased counseling. You give pros and cons of everything, but every time it may not work because of the lack of education, method of training during the residency. In residency, do you ever remember that you have said to the couple or the family that, okay, why we are doing cesarean section? Because if we continue the pregnant, if we continue the normal labor, you will have this complication. If I do forceps, these are the complications. Normally, okay, CS में ले लो, CS करो, बाहर sister sign कराएगी and the job is done. See the entire system, the same thing. Now, our daughter Forum is appearing for RCOG exam and she has just appeared for part 3. I used to listen to the conversation or a talk or a counseling sessions.
Yes.
Their counseling sessions are brilliant. They
Yes.
give you pros and cons, and they said, okay, you tell us what to do. Okay, I am not responsible, whatever. That system doesn't work in India also, again. So there are things that, but the counseling is brilliant. Whenever she was undergoing these exams or those, we have to learn. We have to learn. Unfortunately, in India, there is a system called shopping. If you say something is abnormal, next day or the same day evening, that patient will go to your neighbor.
Yes.
And that neighbor will say, okay, let us continue, wait, don't do anything, just wait. I mean, every system in India, in obstetrics, has got pro and against. If you say pro, somebody will say against. If you say against, somebody will say pro. Both are correct. But
True.
these being a private practice, the system of a private practice in India is something. And there are many influencers in the family in that, for that particular lady.
Community.
You have elders which are playing, and there are many social, I would call them as the creatures. They will influence. No, abhi mat karo, aisa mat karo, vaisa karo. They have got nothing to. They have no idea what they are talking, but still that couple will follow. Acha, inhone bola hai, chalo aisa karo. So it goes on and on, and so there are many things. There is no government support for any congenital defect to the fetus if it delivers. A cerebral palsy child, they have got no system. So there are many things which are all there, but medical litigations are there. You should be constantly worried, mere pe koi case na kare, there should not be any medical litigations. So you are worried for medical litigations also, and you have a sympathy for the patient also, and the
Yeah.
patient doesn't have any clue what is going on. So you have got a very complicated scenario occasionally you may come across, and these things makes your life really difficult when it comes to ethical implications.
True,
Right?
sir.
You have to have, there are many ethical dilemmas. Access to the system, access to the knowledge is really limited. Hardly there is a concept of informed consent. We believe that informed consent is valid if you have talked to her personally. The same thing if you have written everything, and now somebody says you have to have a video consent and you have to record everything. Now there is no
Oh,
fixed
end to end.
there,
Yeah.
there is no fixed rule in India. You can do whatever you feel appropriate. Okay, so everything is correct and everything is wrong. So there are many things. First, then there is no public private. I mean, there is no education coming up from the government to the patients. There are very few leaflet. If you go to any government institute, you will hardly find any education leaflet given to the patient. They'll give you a simple book where it is pulse BP return and fundal light this many weeks return, tablet FECA, done, go home. You have nothing. So these, in this case of system, this dilemma always be there, and I think it'll create more. We need little more change from the training itself, training of a resident, training for all FOGSI members. I will request you and Sunita also, so that if at all you make some kind of educational leaflet, you may supply to some of the institutes so that they can reproduce and make it.
Make it easy. Thank you, sir. Thank you for that. So, if I ask you, like, tomorrow, one technology that is going to decide the future of fetal medicine and fetal diagnosis among the various new technologies, what would your choice be, sir? In terms of,
My choice would be a combination, amalgamation of brilliant ultrasound machine. There has to be, see, I tell you one really brilliant AI which has been developed by one AI company, that is known as scan of scan of fetus is the full form. They call it a scan of fee. The moment you do any biometry measurement or a Doppler or any malformation, the moment you measure it, there is going to be a tablet or iPad or any tablet on side of your ultrasound machine. There's going to be a pop-up. And okay, look, this is abnormal. So then, if you enter any malformation that you have got a corpus callosum agenesis and an absent nasal bone, say for example, if I ask you a question that if a lady you are examining who has got hypoplastic nasal bone and absent corpus callosum, how many syndromes will come in your mind?
quite a few.
Maybe one or two or three. Am I
Mhm.
right? There are 18 syndromes which can have a combination of these two. And we do not know all these
All
18,
of them on the back of our
right?
head.
And
Correct.
we do not know what is the phenotype of all of that. So this is exactly what a scan of E will do. That on a tab, on the moment you click both malformation, it will give you the list. Okay, that okay, look for these 18 syndromes or the phenotype of these all syndromes. And then it also guides you that how to investigate these syndromes.
To go about it.
So it's all from the you are doing scan. From scan to the diagnosis, method of investigation, that will release your stress and the tension, what to do further. And the counseling is going to be easier. So I give a lot of credit for good ultrasound, good amalgamation of AI with all of these
Thank
fetal
you.
diagnosis, and then advanced technology of the fetal diagnosis. I tell you, double marker, triple marker, quadruple marker, they are going to die. It's going to be early fetal anomaly testing. NIPT will take over, and then whole genome sequencing will take over. I see after the 5 years, it's not the karyotype. Karyotype QA-PCR will
Almost gone.
they
Yes.
will die. Microarray will, I expect that will also die, but it will eventually whole not exome, it's whole genome sequencing, which is going to be the primary investigation, and then if needed microarray. This is what I can foresee 5 years down the line. This is what going to happen. So you will have amalgamation of better technology of ultrasound, better diagnosis using AI to identify the disease pattern, and then going for whole exome sequence, I mean whole genome sequencing, and try and identify, pinpoint the disease, and then you will be able to counsel, and then you will be able to predict what is going to be the outcome of that particular child, and what is going to be the same importance you should give to the evaluation of the index case. We hardly find a pediatricians or a newborn specialist hardly try to investigate the newborns or the pediatrics with an index case or with a convulsion or the cerebral palsy or any metabolic disorders. We never find it is evaluated completely. What gene is it responsible? We never find the couple which is being appropriately investigated. So these our associated fraternity also needs a better evaluation and the
Only
counseling.
when they become pregnant, then the whole thing.
And we don't have time, because in India it is 24 week.
Yeah,
Before that, you have to do everything.
maximum possible. Yes, sir. So this AI technology you mentioned, it is available now, and it is,
Yes, it is
can,
available. It is
yeah.
available. And I think I think I should discuss to the company that if it provides the all Foxy members at very subsidized cost, or on a monthly rental basis, maybe 500 or 1,000 rupees or 1,500 rupees. I mean, it can be very
Great.
wonderful for
Yeah,
every.
absolutely. Sir. Yeah. Thank you. So, so again, in these, I mean, you have published, when you talk about certain, when in your books as well, you have these basic thumb rules, where it is just basics we talk about, and very easy points, practical points. So, what do you think, in terms of how are we, like, in terms of expanding these expanding technologies that we have? Do you think that which way are we going, or we need to stop and think that we first use your basics, or then and then go to that? I mean, what are we heading for? Where are we heading towards? At one point we say that, we should try and make use of whatever minimum we have. And then the other point we're also saying. So it is coming back to the same thing as, what
See, I tell you again, we can't put it on paper. I have done a basic ultrasound. There is no level 1, 2, 3, 4 that I have done level 1 scan, and so I cannot. I have done, although I have done scan, I have charged patient whatever amount, 100, 200, 500, 5,000, doesn't matter. But if you have missed any malformation, you are liable.
life? Yeah.
Okay, so there is no level. So always make your scan. Always you should do it scan if you have learned it. So never ever just chalo scan kar liya. No, ultrasound is not like that. You should learn, then perform a scan. The newer concept in future is going to be the early detection and the diagnosis. That's the first thing we are heading towards. So it is not the basic what we are doing right now. It's not that part. It will go to the early and more precise diagnosis. So that
Okay.
a complex cardiac disease, which we used to diagnose at 20 to 24 week, now you can diagnose at 12 week. 13 week you can diagnose. A twin to twin transfusion syndrome, you can predict at 12, 13 weeks. Major lethal malformations, whether it's a brain, heart, or anything, you all can be diagnosed at 13 week of a scan. So make sure that you have diagnosed those things. You can't have acrania delivered. You can't diagnose acrania at 32 week of the gestation. It's
Criminal, actually.
it's you shouldn't have those kind of things. The moment you write you have got a multi-fetal gestation, if you write it's a twin pregnancy, again it's a criminal aspect. You should not do that. It has to be monochorionic or a dichorionic twin, right? So because it has got a very different kind of outcome, you should always put it across like this.
So this relates to the expanding technologies in the ultrasound itself, isn't it? We are talking about
Yes.
3D, 4D, that's a different part. But now with the new machines coming up, with so much of technologies there with, so that
Huge.
itself. So would you like to talk about those evolving? I mean, every time we come up with a new machine, we're completely awestruck, and about how much they can show us about the fetus.
The capacity of ultrasound machine is huge. Any institute, I would put it across that, not any, but let me put it across, majority of the institute, we are not using the ultrasound machine to its best of capability.
Yes, capacity, yes.
Right. The capability of machine is huge. We rarely utilize its full potential. So we have to learn that art of using the machine. If you have got a 3D, 4D volume probe, if you are not using it even for auditing yourself, it's not correct. Basically, you have a machine, then you should utilize it more optimum. New upcoming things are there are good color Doppler tools which are there. New brilliant what we call a silver technology which is coming up. Then there are more flow technique which are coming up. The radiant flow is there. Then now it machine also tells you about the movement of the RBC, which how they are moving. So that is also coming up in a very near future. It will tell you that, okay, in the heart, these RBCs are moving this side and these RBCs are moving this side. So those, it can track the movement of those RBCs. So there are many things which are coming up. New sections which is in utero procedures.
Yeah.
How you are going to deal with in utero situation in India, still we have 5 to 6% Rh negative mother, and still huge amount of any
RH.
patients with Rh sensitization which is coming up. There are many aspects of it. Increase in section rate could be one of the factors. Second worst ever factor is availability of Mifi and misoprostol kit over the counter. Right. Rh negative mother, she has no idea what these
What
kit
her blood group is also. Yeah.
can create. She has no idea she is Rh negative. She has idea she is Rh negative, but she has no clue that she should have anti-D injection after taking this popping
Yeah.
these pills. So they increase. There was a very high rate before 20 years. Then before 8 9 years, there was a dip. Now sudden there is a rise because of these availability of kits, which creates lot of issue. Now there is a trend change in the trend. Every patient needs a perfect baby. They
Yes.
want everything correct.
Right.
Even after we used to say that recurrent pregnancy loss was diagnosed, should be diagnosed or called after 3 losses. Now, which lady is going to wait for 3 losses? No.
After one loss, they want
One loss, they want investigations, right? Why? Next comes why. Sir, मेरे का पैसे का प्रॉब्लम नहीं, आपको जो करना है करो, मेरे को वजह बताओ क्यों. So they want, okay, you spend money, I have no problem. But let me know, I do not want these to happen. I don't want mental trauma again. I do not want physical trauma. I have no time for these pregnancy, abortion, and making this and that. So there are many things which are changing. So we have a really very different personalized prenatal care now.
Yes.
Those books are we learn on undergrad days are different, postgrads even different, and a private practice is completely different.
Totally different. Yes.
So you have to have that. And now we have a better understanding about the fetal development, fetal behavior in utero. That makes not only our life more complicated, because now we understand that something is normal, something is not normal, and there you need a better technology, better things to make the diagnosis and make the things understand. Again, the same ethical dilemma, making them understand about some of the situation where they may have some idea, somebody may not have complete idea, and a lack of education will also create a lot of other issues for not only for
Social.
us, for
Yeah.
them also. For social things are different. As I told you, many influencers are going to create problems. So many things in India, the things are we are, I would put it across, in science we are probably better in many aspects than the Western world. There are social aspect, we are far behind in many aspects than the Western world.
Pros and cons are there.
So we have to cope up with both the system simultaneously. That makes our life very tricky and challenging.
Challenge. Absolutely. Yeah. Very interesting as well. So what about, you said about telemedicine. So what about using portable ultrasound machines, with these into low resource settings? Does it help? I mean,
Yes.
it's an area which was there, and now it was obviously with this PCP and DT issues. I know we are talking about, expanding technologies, but if telemedicine doesn't work,
If telemedicine doesn't work, I would probably advocate one transvaginal scan at between 16 to 22, 24 week, one probe, and do one thing. Make them learn to measure the cervix. Make them learn, is the placenta nearby the cervix. And the third, a uterine artery Doppler. See, the highest point why I'm giving you this idea is because you have a preterm birth, placental and antepartum hemorrhage, and third is preeclampsia and eclampsia. They are the killer to the mothers.
still in India, that
Right.
means
In India, because it is creating this, if you can take care of this at one vaginal probe insertion, and your PHC, CHC can send the data, or any worker can send the data about PI of uterine artery, you can segregate high risk versus low risk. And that's what you can probably, you can separate them, you can follow up high risk pregnancy, and you can take care of them. One more system which you can change, I think we should think about it, and as a chairman of fetal medicine and genetic community, I'll probably give you one brilliant idea about that. That is thalassemia and sickle cell anemia. Okay, see, the concept right now is what? You ask that all college boys and the girls should be evaluated by doing HB electrophoresis. That's what is being done in India right now. Okay, in Gujarat, they are all are screened for that.
Yeah. Not in all states, sir, but yes, in some states.
But in Gujarat, it is being done like that. Many states, they are following that evaluation. Now, the issue is they never say if there is a matchmaking which is going on, ladka ladki dekhne gaya, ladki ladka dekhne gayi, they'll never say that I am thel minor.
Yeah, it's a very sensitive issue.
Right, because it's a very sensitive issue. So the entire concept is blown away. So you have no clue. You are spending huge amount of money and you end up in delivering all thal major child after their first pregnancy. That's terrible. And then in second pregnancy, they'll come, now we please evaluate us for thalassemia. Instead of that, let them marry of their choice, whatever. Then after the marriage, just withdraw 2 cc of the blood with a consent and get HB electrophoresis and HIV and CBC. So you diagnose anemia, you can treat the anemia, you can have HB electrophoresis, you can diagnose sickle cell, you can diagnose thalassemia, and you can diagnose HIV. All major causes of pregnancy related complications can be taken care. Then you give a green card or a red card. You don't say that lady that you are thel minor, husband you are thel minor, forget about it. You give them green card, that means she's HIV, both couple is HIV negative. She is not thel major, or couple one is major, both are not thel minor. Same is they don't carry sickle trait in them, and she is having good hemoglobin. The moment you take care of this, in general, you are covering so many problems at a time.
Major aspect of, yeah.
So it's one single examination can take care of so many complications of a pregnancy where inheritance is an issue and which is never disclosed during their first pregnancy. So you have a lot many things can be covered at a go. So this is a completely novel idea that you evaluate just after the marriage.
Yeah.
Just after the marriage, maybe after a month or so, once they are all set in their married life, get 2 cc of blood from both, sending from PHC or CHC or something. You promote it. We promote it like that. Get investigated so that you have your child healthy.
True, sir.
That's the concept.
I just looked at the time and it's 8:57.
Yeah.
It's been so wonderful. But it's just, yeah, I think Odisha has started this, where the birth at the marriage registry, they sort of book all these patients and then they follow up. But I think, sir, one last parting thought, your advice to the young generations who are so much, they look up to you for the expertise and your use of various expanding technologies. So one word of advice, a word of wisdom to our upcoming fetal medicine specialists, and for us also who are there, neither here nor there.
You need to be focused, first and foremost thing. No, I want to learn the art. Okay, you have to be little crazy in that part. Okay, that's the first and foremost thing. So, and second, you have to learn your anatomy, embryology. The moment I can guarantee you that for a obstetrician, a gynecologist, embryology, anatomy, and genetics, we have a huge far distance, and we have no clue what is going on in these three areas. I will be really very honest about it.
True,
Okay.
sir.
So first, and those who are inclined to learn ultrasound and fetal medicine, you have to have these three things: anatomy, genetics, and the embryology. The moment you have learned these three, then please make sure that you have known your ultrasound machine to the best. Every knob, every switch, if you press one, what is going to happen on the screen and what you want to see, try to predict what
Play
can
with it.
happen to the fetus.
Yeah.
Then you should not only think like a focused, okay, very narrow focusing. You have to have a broad vision, a lateral thinking. I'll call it as a lateral thinking. The moment you have developed a little thinking that it could be not only this, it could be that, or it could be this also, then you will learn the art of ultrasound. And you have to love the art and the color. The moment you start appreciating beautiful things, beautiful color combinations, then you
So
are
beautiful.
to it, you will go far ahead than your any of the colleague. I can guarantee you this much.
We can bring out the same images as you get when you
Far
show.
better you can have it.
Thank you, sir. Thank you for sharing your insight. It was so wonderful talking to you. I just realized it's 9. So I think it is clear that while we are making scientific leaps, we also need to make ethical and equitable strides as well in our expanding technologies. So thank you once again, sir, for joining our podcast and giving us such wonderful words of wisdom, knowledge, and learning.
Thank you.
Thank you.
Thank you.
Thank you for joining. Thank you.